at the Newcastle IVF Australia clinic called Hunter IVF. I'm also an obstetrician who delivers babies, and because I deliver many of my own patients' IVF pregnancies and fertility pregnancies, I've had years of experience looking after IVF pregnancies. It makes me really aware that IVF pregnancies can be complex. Tonight I'll talk briefly about some aspects of the care of IVF pregnancies, but I'm happy to take your questions about any aspect of IVF and pregnancy. Following my patients through from fertility concerns, treatment and into pregnancy means that I can help with the anxiety that's almost universal in this situation. I know how long and hard you've worked to get to this exciting moment, and I know the thought of that positive pregnancy test is what you've been wishing for. And the worry and anxiety is really normal and understandable. It's often helpful to have regular contact with your fertility specialist as the follow-up results come in, and have a plan about your medications and how they transition into pregnancy care. If you're moving from one doctor to another, it's really good to have a good understanding of yourself about what to do with your medications so that you don't get too concerned as you move from your fertility specialist to your obstetrician. Making sure that the pregnancy is ongoing and correctly located is really important, especially in the first 2 to 3 weeks. Most people don't understand that ectopic pregnancy, which is a pregnancy that's located in an area that's outside of the uterus, is actually more common in IVF pregnancy. It's really hard to fathom that when you're sitting there and watching your embryo transfer, often with ultrasound guidance, and you see the embryo carefully placed into the uterine cavity, into the correct location. And to then understand how it can get from there to somewhere else. But it's common that IVF pregnancies can be ectopic, and that means it can be low down in the cervix or in the tube or elsewhere. And we know actually that the same mechanism that creates ectopic pregnancies can actually increase the risk of things like placenta previa as well. You're probably all familiar with the first trimester screening, and it's a really important screen. You're probably also all aware of non-invasive prenatal testing, and it really hasn't replaced the first trimester screen. The first trimester screen is a really important test to have in an IVF pregnancy. It doesn't just screen for chromosome abnormalities, but it screens for early structural abnormalities. It can predict the risk of preeclampsia, of preterm delivery, and of placental dysfunction and growth problems. So it's a really important test to have. Thanks for your questions. So questions are just starting to come through now, which is really good. So I've got a question here that says that aiming for too many eggs can reduce the quality of the eggs, and is there an ideal number of follicles to aim for? How many eggs would you aim for with an AMH of 14.9? So I guess it's really nice to be able to have the option of a fresh embryo transfer, and if you create too many eggs at the time of your egg collection, it's much safer to have a freeze-all cycle where you don't have an embryo transferred back. And although we know freezing all and subsequently transferring embryos is a very safe option for people who have overstimulated and gives you an excellent chance of future success, it probably isn't ideal. So I guess the best outcomes from IVF pregnancies are where there's somewhere between about 8 and 15 eggs collected. And that's about how many I would aim for with an AMH of 15. We know though that if you collect more than that, it can give you further chances down the track, so that if you were having a purposeful freeze-all cycle, say in the case of genetic diagnosis, then maybe aiming for a few more than that would be reasonable. but I think aiming for no more than about 15 eggs is a really excellent chance of pregnancy. Hi everyone. Seems like we're having a few technical issues tonight. Hopefully everybody can hear me now. Thanks everybody for your patience. I think we've got dodgy internet tonight. I'm going to blame homeschooling and working from home. So it's been really nice talking to you all tonight, and hopefully your questions will be coming through. But just to go over some of the things that we've been talking about while Facebook's being down, is that it's often really helpful to have regular contact with your fertility specialist as you move into the pregnancy phase and out of the IVF phase, so that you have a really good understanding of what your results are, what they mean, what treatments you're on. You're often on complex treatments, not just progesterone support, but sometimes also estrogen and other medications. And all of these treatments need to be continued for periods of time and sometimes weaned off. So it's good to have an understanding of what treatments you're on and how these are going to dovetail into your pregnancy care. So ideally you would understand these treatments and your fertility doctor would be able to hand those over to your obstetrician, or in my case the whole thing just flows through. So we know that it's really useful to have an idea early in the pregnancy that things are going okay, because in particular knowing where the pregnancy is really important. We know that IVF pregnancies are more likely to be ectopic pregnancies, which often people aren't aware of. And so when you see an embryo carefully put into the uterine cavity with ultrasound guidance, it's often difficult to fathom how it can end up growing somewhere else in the uterus, outside of the uterus, in the tubes in particular. But we know IVF pregnancies can result in ectopic pregnancy, and we know that that same mechanism actually is probably responsible for the increased chance of having placenta previa with IVF pregnancies as well. So it's really important when you've got an IVF pregnancy to have a good first trimester screen. So first trimester screening is performed with blood test and ultrasound at 12 weeks pregnant. And it gives us a really good idea about the overall risks of the pregnancy, and hopefully allows us to introduce some interventions that will help keep the pregnancy as safe as possible. So we know that first trimester screening will screen for chromosome abnormalities, but it will also screen for structural abnormalities and give a really good indication about the risk of preeclampsia, which is high blood pressure of pregnancy, of preterm delivery, and also of placental dysfunction and growth problems. And we know that there are some interventions that can be introduced at that stage of pregnancy to help modify those risks. So for example, if the risk of preterm delivery is thought to be high, then we can continue the progesterone support that you've been on early in pregnancy and continue monitoring with ultrasound so that we can see the cervical length and monitor that and manage that pregnancy to try and make sure that the risk of preterm delivery is reduced. We know that interventions like low-dose aspirin and sometimes Clexane can also improve the outcome of placental function. We know that there are lots of other things that happen to you when you are pregnant that you can there's lots of other things that happen to you when you're pregnant that can be an issue and that might play a role in your pregnancy. So things like surgery for fibroids, insulin resistance and so forth. So thank you for your questions that are starting to come through. So there are a couple of questions from the first video. So it says that, is it true your eggs decline after 35? I'm turning 36 and I'm considering freezing eggs with an AMH of 8 or 9. So I guess we know that if egg freezing is a useful resource, and frozen eggs in the freezer is a really useful resource for you moving forward. So I guess the problem is that by the time people start to think about freezing their eggs, often their ovarian reserve is declining. So I guess the question of freezing your eggs at 35 with an AMH of 8 or 9, it would definitely be better to freeze your eggs at 35 than it would be at 40. So probably the ideal time to look at egg freezing would be about that age. And I think if you've got the capacity to do that, that would be a nice resource to have. So I've got a question here that you're on a natural frozen embryo transfer cycle, and how do you determine when to transfer the embryo? I've heard clinics do urine ovulation kits. Is it important to check the endometrium? So I guess we know that at Hunter IVF we do most of our embryo transfers natural cycle, and it is important to make sure that you identify exactly the day of ovulation. So embryos that are frozen on day 5 are expecting to get into the uterus and implant and grow with an endometrium that is a day 5 endometrium. And so it is really important to identify exactly the day of ovulation so that you can put the embryo back at the right time. So that generally is done with blood testing so that we can identify when the LH surge is and when the progesterone rise is. And we can also look at the level of estradiol. We do sometimes do ultrasound to look at the endometrium. So if there is a concern about endometrial thickness, then that is something that we can do as well. And all of those things allow us to time the transfer correctly, and timing is really important. So that's why if we're doing a natural cycle transfer, we're prepared to do a transfer any day of the week. So it might be that we're seeing you on a Sunday or a Monday or whatever time is right for your transfer. So I guess I've got a question here saying I have a 12-year-old daughter and have been trying to conceive for 3 years, had a low progesterone in the luteal phase, did 2 rounds of Clomid. Fertility specialist said to keep trying. So look, I guess if you've got a 12-year-old and you've been trying to conceive for 3 years, I'd probably suggest that time is starting to be a bit pressing. So it may well be that the timing of your pregnancy to make sure that your family spacing is what you want, or if your own age is becoming an issue, then I think it's possibly time to move past ovulation induction interventions and consider IVF. So I think it would be definitely worth at that point getting some other options other than ovulation induction, because time is, and how long you spend before you move to IVF is really individualised for you, but it sounds like to me from your question that it is starting to be an issue for you, and it may well be that getting some extra advice about alternatives might be useful. So I've got a question here about fibroids, and fibroids are a really good example of how conditions that can affect fertility can go on and affect pregnancy. So we know that fibroids are common and that they don't always affect the chance of conception at all or significantly. So fibroids that are small and are not submucosal, so that means they're not right under the endometrium, probably have a reasonably small role in getting pregnant, and removing them is relatively invasive and can be quite destructive to the myometrium, to the muscle of the uterus, and it's not something that we would usually do. So I think if you've got a large fibroid and you've been trying to conceive, or if the fibroid is clearly submucosal so that it's sticking right into the endometrial cavity and distorting the uterine cavity, it would be worth considering having those fibroids removed prior to embryo transfer. Fibroids can certainly grow during the time that you're on fertility treatment, and they can grow during pregnancy too. But you've got to remember that the time taken to remove fibroids and then the healing of the uterus and the fact that the uterus then has a scar in it needs to be balanced up. So I guess fibroids are something that's best individualised. Having a good ultrasound so that you can assess the size and location of your fibroids, and having sometimes other surgery like a hysteroscopy to assess the cavity might be useful to help you and your fertility specialist work out whether or not a fibroid is able to be left or is best resected prior to treatment. I missed my question, is cut off. I'm 37 with an AMA of 19, so this is Holly. So 8 to 15 would be what I was looking to achieve. I begin my fertility journey in 5 weeks. Absolutely. Yeah, that would be about the right number, I think. If you can manage to achieve that kind of number, you're going to give yourself an excellent outcome at 37, Holly. So what we'd be hoping for is that you would have a nice embryo for transfer, and it would be really great if you had an embryo too to put in the freezer. And that would mean that if you were unsuccessful, you could try without having another egg collection. But even more importantly, if you're successful, then you can go back and have another pregnancy later on, even if your ovarian reserve has decreased, making conception harder later on. Yeah, I think that kind of number is excellent. So I guess we've got lots of other things that we can talk about. So the next thing that I will talk about while we're waiting for some questions to come through about pregnancy, about IVF, would be that the timing of delivery for IVF pregnancies is often quite controversial. So we know that from studies that an induction at 39 weeks is a really safe way of managing a well pregnancy at term. So your friends and other social groups won't tell you this, but we know from studies, and certainly in my experience, that induction of labour at 39 weeks has got an excellent outcome, and the chance of failed induction, of failure to progress in labour, of needing an epidural for pain relief, of having a caesarean delivery, of the baby being admitted to the nursery, all of these interventions that we study are not changed by the fact that you've had an induction of labour. So we know that IVF pregnancies are at risk as you move towards term, and it would be ideal, I think, if a pregnancy makes it well and happy to 39 weeks, to look at delivery somewhere between 39 and 40 weeks. And to be reassured that that can be really safely achieved if the pregnancy is well at that stage. We know that IVF pregnancies should be closely watched for growth and placental function as pregnancy proceeds. And I'd often do a scan looking at growth and wellness late in the second trimester and again in the third trimester, and often more than once, so that we can make sure we time delivery appropriately. So I've got a question here from Kath saying, I'm 33 with an AMH of 5, and you've had 3 cycles on maximum dosage with only 3 to 4 eggs collected and poor fertilisation. I've got adenomyosis and endometriosis, and my doctor's suggesting my eggs are poor quality and donor eggs are an option, but we're not ready. So look, I guess it's a really difficult decision about when to move to using an egg donor, and I guess in my experience everybody moves to that decision at a different pace. Some people are ready to move to using an egg donor if you've had poor outcomes in a cycle or 2, and other people are prepared to try different things, try different cycle styles and doses, to see whether or not you can achieve a pregnancy with your own eggs. And I really understand that for many people, moving to using an egg donor is a really big decision that's very hard to make. It's a bit unsure from your question whether or not you've actually had any embryos that have got to embryo transfer or not. But I guess in that scenario, it's reasonable to consider different stimulation styles. So, and it would be reasonable to try different medications and different protocols to see whether or not a better outcome can be achieved. We know that there are some embryos that are poor quality and not making it to day 5 for transfer because they don't have the correct genetic material to allow them to do that. But there are some embryos, a small number, that might benefit from a transfer on day 3. So on occasion that would be something we could do as well, where a cycle is yielding low numbers of poorer quality embryos that aren't potentially making it to transfer. So I guess I'd suggest that there probably are some other ways that we could go about trying to achieve a pregnancy with your own eggs before you feel like moving on to an egg donor is appropriate. So hi Janine, your question is you just wanted to ask what you can change to help to get embryos to freeze. Out of 4 embryos, none of it made it to freezing. Yeah, look, I guess that's a really difficult question, and it is really ideal to get embryos in the freezer, but it's not something that everybody can achieve. And we do find that there are a proportion of people who are always going to have a nice embryo for transfer, but may not get additional embryos to freeze. But same answer really as the question before, sometimes changing stimulation protocol, drugs that we use, will sometimes allow you to achieve slightly better outcomes. So it is a really difficult problem though. I'm hopeful in the end, if you are getting a nice embryo for transfer, that's going to be the absolute key to success for you. So just looking at a question here. So from Perna, who says that she's, it sounds like, got a lot of problems of prolactinoma, maybe polycystic ovaries, irregular periods, have been off contraception for a year and not pregnant. So, Perna, it sounds like you've got several complex problems going on there, and it's a bit difficult to work out what's going on. But certainly if you're having irregular periods, then it may well be that you're not ovulating, and it may well be that wasting more time trying on your own at home might not be the thing to do, and it might be good to go and see a fertility specialist and get some more information. So I guess we know that for some people irregular periods are anovulatory periods, and so that the lining of the uterus is building up and falling off rather than being triggered to shed off, so that people sometimes think that having a period means they're ovulating, but it doesn't always mean that. And it may well be with your irregular periods that you're not ovulating. It sounds like there's a few different things in your history that potentially could be responsible for that. So certainly prolactinomas for some people will cause irregular anovulatory cycles, and polycystic ovarian syndrome is certainly the commonest way or commonest reason why people are anovulatory. And there are some medications that can be used. We often use ovulation induction medicines like letrozole and clomiphene. And some people end up needing IVF treatment as well. So the question from Hannah, how many days after ovulation is good for embryo transfer for frozen embryos? So Hannah, I guess we aim to put an embryo back on the correct day. So if an embryo was frozen on day 5, we aim to put it back 5 days after ovulation. And we know that if an embryo was was frozen on day 3, that it would be able to be transferred back on day 3. If you've got several embryos frozen on day 3, then what we sometimes do is to transfer them back on day 5 after we grow them on for a little while longer. So I've got a question here. Could a byproduct of miscarriage or pregnancy that calcify my uterus be a reason why I don't have successful transfers? So Erin, that's a really good question. We know that on occasion, when people have had uterine instrumentation or surgery, in particular in the setting of a recent miscarriage, that it is possible that you can get a condition called Asherman syndrome, which is where there is scarring or adhesions inside the uterus. So yes, that is possible. I guess if you have had a previous miscarriage or a previous pregnancy, in particular if you had a curette in the postnatal period, then it would be worth considering seeing a fertility specialist to have that investigated. So we can investigate the endometrial cavity in a few different ways. We can do that with non-invasive means like a hysterosalpingogram, or with a minor surgical procedure called a hysteroscopy. And if we do find adhesions, they can be divided. It is a tricky problem though, because it's not always something that we can correct completely. But yes, it's definitely a possibility. So I've got a question here from Jane in Mackay. That's a long way away. So just asking about a wait time. So no, we don't have waiting times at our clinic at Hunter IVF. So we're able to start you whenever you're ready to begin. And the timing in which that you start your treatment is going to be really up to you. Obviously, if you're travelling, that's going to be a bit of a challenge, and it would be worth talking to your fertility specialist and making sure everything was ready to go, so that you're not wasting your time. You need to make sure that things are ready for you, so that if you do travel down from Mackay, that you're able to just go straight ahead with treatment. And we do have many people who travel for treatment, and sometimes that means that we can do some of your preparation for treatment where you live, so that you travel down and have as little time away from home as possible. So I guess there's a question here saying, does IVF cause cancer? We haven't got a lot of good evidence for that at all, but we know that people do get concerned as you have multiple cycles of IVF. So thankfully these days, with excellent techniques and good quality laboratories, that the number of people now having multiple cycles of IVF is much lower than it used to be. So I don't have concerns about IVF causing cancer in my patients. So I've got a question here from Catherine saying, how much does removal of endometriosis affect IVF success rates? So we know that superficial endometriosis definitely affects natural conception, and that surgical treatment of it will improve your chance of natural conception in the months following your surgery. The benefit may not be really long lasting though, and so for many people, they have surgery for their endometriosis, and if they haven't conceived in a period of time, they might move on to IVF treatment after that. But the treatment of superficial endometriosis probably doesn't, for most people, play a huge role in the success of IVF. So I don't generally, if people are moving to IVF for other reasons, for example, if there's poor quality sperm or age is making time pressing, I don't usually do a laparoscopy and aim to treat minimal endometriosis. You can go on and have IVF without that. Occasionally, if it's unsuccessful, you can come back and consider that as a later thing. All right. Well, I guess the risk that frozen embryos won't survive the thaw. That's a really good question, and thankfully that's something that has improved markedly over the years that I've been doing IVF. And in our clinic at Hunter IVF, we know that in excess of 95% of our embryos will survive the thaw. So if we put an embryo in the freezer, you've got at least a 95% chance that it will thaw and able to be transferred. And that's really great to know. We know that if you've got more than one embryo, and as we thaw it, if that embryo doesn't survive, we can go on and thaw another one for transfer. So hopefully that would only be a concern if you only had one embryo remaining in the freezer. Okay, everybody. Well, I think we're getting on to past our time frame. I know we had a little bit of time down as we were trying to get computers sorted, but hopefully we've gone through some of your questions. If you've got any further questions that you'd like to ask, don't hesitate to give a call on the 1800 number, and we can direct your questions either to myself or to any other specialists that you'd like to be interested in. So thanks a lot for listening tonight. It's been a really fun experience. Hopefully the internet will continue working for you for the rest of the night. Okay, good night everybody.